Good morning to you all and good evening to those who are logged in from India. It is my pleasure to be a part of this illustrious group of people who have conducted these sessions. And I really thank Dr. Satyapati for having invited me into this august group of people. He had suggested that I would speak on something related to gallbladder and gallstones. So I thought of speaking on gallstones and gallbladder interrelationship, newer insights that we have gained in the process of working in this area. Gallbladder and gallstones are intensely intertwined in their relationship with each other. So gallbladder with its cystic duct, which goes and joins the common hepatic duct, forms the common bile duct. And the stones tend to stay in the gallbladder and sometimes can get pushed down into the CBD. Gallbladder is actually a disadvantaged organ. It is the thinnest part of the GI tract. It is physiologically prone to stasis. It has a thin, interrupted muscle. It's a weak muscle, and it empties its content actually against gravity in the standing position. And it is dependent on the sphincter of Oddi to relax so that it can empty itself. The sphincter of Oddi is dependent on cholecystokinin, which is released from the duodenum. So the gallbladder on its own cannot initiate contraction. It is dependent on various parameters and thus prone to stasis. Inside the gallbladder, we have the bile, which comes from the liver, and the liver conjugates a lot of toxins, environmental toxins, and pushes it into the gallbladder, where its content goes on increasing in concentration when it is being stored in the gallbladder. So the gallbladder mucosa is exposed to a large number of chemical toxins, and also because of stasis may be exposed to a lot of bacteria. So combination of this milieu, if there is stasis, is going to increase the toxicity on the gallbladder membrane. Also, if you see that this part of the gut is not very well perfused, and a combination of all these makes gallbladder actually a disadvantaged organ of the body. What are gallstones? These are any hardened deposits within the fluid of the gallbladder. Quite often on ultrasound, we detect it as presence of an anechoic shadow behind a hyperechoic structure in the gallbladder lumen, which is usually in the dependent part of the gallbladder, and it moves and shifts. So there are three types of gallstones: cholesterol gallstones, pigment gallstones, and other rare stones. So this is a typical cholesterol gallstone, a single one, which is pearly white in color with the surface which is as if it is corrugated. And you have big stones, which are a combination of cholesterol as well as bilirubinate. And all of these are usually faceted, and these are multiple. This is the commonest kind of stones we see in North India. And cholesterol single stones are the commonest we see in certain parts of the world. And if you go down to southern part of India, you see more and more pigment stones because they see very less of cholesterol stones and mixed stones. However, the demography and the epidemiology is changing with increasing metabolic syndrome in the country. We will be seeing more and more of mixed gallstones all over the country. Earlier on, when Professor Rakesh Tandon had done a study, community-based study, he found 5 to 6% of people having gallstones in the community. But recent studies are showing that it is going up to 10 to 12%, indicating that there is an increase in the prevalence of gallstone in the community. You can see here that the pigment stones, the brown pigment stones, are more like slush, which is all organized there. And these are usually soft, and they would kind of crumble whenever you put pressure. Whereas these cholesterol stones are one of the hardest, and they are hard and dense, and they can cause more tissue injury sitting on the gallbladder. And also you can see that the surface is irregular. So when we did a scanning electron microscopy of the cholesterol stones, we found a lot of bacterial colonies sitting in these crevices and biofilm formation on top of these cholesterol stones. So this is how a traditional gallstone looks on an ultrasound. You see a hyperechoic structure with a distal acoustic shadow. And here you can see multiple gallstones sitting inside the gallbladder, giving distal acoustic shadow. Quite often the radiologists focus on the stone, but it is very important to look at the gallbladder wall. Here you can see that the gallbladder wall is thin. A normal gallbladder wall should be less than 2 millimeters, 1 to 2 millimeters. But here you can see that the gallbladder wall is becoming thicker. And if we have found that if the gallbladder wall is more than 3 mm, it is a matter of concern because there could be underlying chronic cholecystitis. We have found that they are at increased risk to have associated metaplasia. So whenever you get an ultrasound report, apart from looking at the gallstones, please look at the gallbladder wall for any focal or diffuse abnormality or any asymmetric lesion in the gallbladder wall or a polyp in the gallbladder wall. Presence of any one of these things should alert us that this gallbladder may be diseased even if the stones are asymptomatic. Such subset of patients should be under the scanner view. They should be taken up for further evaluation of the gallbladder wall by CT or MRI and seen if they are merit a cholecystectomy even if they are asymptomatic, because over a period of time they are going to degenerate into a diseased gallbladder which can manifest in other ways. Gallbladder stones come in all shapes and sizes. You can see here the varied colors, the varied shapes and sizes that we can see. And the chemical composition of the gallstone, here at one end of the spectrum, you have increased whiteness, which goes with cholesterol stone, and increasing bilirubinate changes the color of stones towards a darker spectrum. So combination of these colors, even on visual assessment, can tell us that there is increased chance of bilirubinate stones, or is it more likely a cholesterol stone? So quite often most centers cannot do extensive analysis of either the chemical composition of stone using FTIR technology or cholesterol content assessment. So then even a simple color assessment can give us sufficient clue as to where are these stones, what are these stones composed of. You can also notice here that in this stone, there are so many crevices, and these crevices are all nidus for bacteria to lodge in compared to the smooth stones like here. And quite often we find that pigment stones, especially which are found in South India, as well as stones which are in patients with hemolytic anemia, do not cause as many symptoms and problems like the cholesterol or the mixed gallstones. We analyzed all our gallstone patients and we found in 220 patients, pure cholesterol stones composed of only 22% of patients, mixed stones were about 70%, and pigment stones were about 7%. This was in North India. And we matched it to the library of the FTIR peaks. So when you find peaks at these designated areas, it is suggestive of cholesterol peaks. And here you are having a peak for cholesterol as well as bilirubin. And here you are having only a peak for the calcium bilirubinate and not for cholesterol. Cholesterol stones happen in the gallbladder due to multiple factors working in tandem with each other. Firstly, there is hepatic hypersecretion of cholesterol. There's decreased secretion of bile salts and phospholipids, which help in solubilizing this cholesterol. So when there is an imbalance in this, the cholesterol tends to precipitate out, and this precipitation initiates stone formation and sludge formation. On top of that, if you have gallbladder stasis or hypomotility or prolonged fasting, then this tends to become cholesterol crystals, which are very typical chipped envelope kind of a structure on microscopy, especially when you use when you use a microscopy to look at these chips. They are birefringent and you can see them under the microscope. And then you have intestinal factors such as stasis, as well as increased efficiency of cholesterol absorption. along with lithogenic genes. All these together initiate the formation of cholesterol stones. Whereas in pigment stones, you have a different scenario. Here, the bacteria and stasis play a major role. And here you can see that in cholesterol stone, also combination of bacterial infection may initiate the nidus inside the patients with inside the gallbladder, which becomes the nidus for formation of cholesterol stones around it. A study in gastroenterology showed that the central nidus of a cholesterol stone quite often have E. coli and other gram-negative bacteria in the center. So combination of that nidus formation followed by cholesterol layering over it, associated with stasis, which allows the stone growth, and in the setting of a genetic factor results a gallbladder to become a gallbladder embedded with stones. And decreased bile acids also promote it. So whenever there is issues of diarrhea and loss of bile salts, that promotes gallstone formation. In contrast, in pigment stones, you can see in bile, you have bilirubin glucuronide, you have phospholipids, and you have conjugated bile salts. But if the bacteria inside the gallbladder initiates release of the bilirubin into free bilirubin by the action of bacterial glucuronidase, phospholipase, or bile salt hydrolase, all these get released, which all together with calcium, dead bacteria, and mucin result in brown stone formation. The risk factors for gallstones are well known, so I will not spend too much time on it. Metabolic syndrome, genetic traits, obesity, women, age, and parity. So the fat, fertile, 40 females, as was said in Bailey and Lau, still holds true. However, in India, we do find malnourished, multiparous women who are iron deficient, vitamin D deficient. They also have increased risk for stones. For pigment stones, there's increased hemolysis, cirrhosis, cystic fibrosis, Crohn's disease, and increasing age. And in brown stones has an entirely different pathogenesis. As I said, it is due to local infection, infestation, inflammation, which is accentuated by stasis and strictures. So this is what we call as the oriental cholangiohepatitis, which have associated brown stones. So as I said, it also affects people of all shapes and sizes, not just the fat, fertile 40 females, but the malnourished, multiparous young mothers whom we see in our country. Gallstones, on the other hand, can now affect the gallbladder. How does gallstone affect the gallbladder? It may stay as asymptomatic stones, symptomatic stones with repeated biliary colic, or it can come to you with a complication such as acute cholecystitis, acute biliary pancreatitis, cholangitis, cholecystoenteric fistula, and can present with metaplastic lesions, dysplasia, and carcinoma in situ and a frank gallbladder malignancy. So you get biliary pain when the stone from the gallbladder goes and gets lodged at the cystic duct, and this, if it doesn't fall back, will cause obstruction, and this will result in acute cholecystitis because of distension of gallbladder, ischemia, infection, and these patients will present with pain lasting for more than 6 hours to the emergency. And if you put an ultrasound probe here, you will get an ultrasound Murphy's sign positive, and these patients have to be treated either conservatively with antibiotics, nil by mouth, and IV fluids, or taken up immediately for surgery, or you take them up for an interval cholecystectomy after the episode of acute inflammation subsides. This acute cholecystitis can also become complicated by perforation of the gallbladder or direct leak into the liver, which is like again a perforation within into the liver parenchyma, or these patients can develop empyema of the gallbladder, or the infection subsides, they can develop a large mucosal. Choledocholithiasis, in contrast, when the stone goes past the cystic duct and gets into the bile duct, can obstruct the bile duct and cause pain, elevated enzymes, as well as a dilated biliary tree. So whenever you see such a kind of scenario, and EUS is very good in picking up these stones, MRCP is very good in picking up these stones, transabdominal ultrasound is not the investigation of choice to pick up CBD stones. If you see a CBD stone, even if it is asymptomatic, that CBD stone has to be treated. And the other scenario is cholangitis. When this stone goes and gets stuck here, the CBD starts dilating. There is bacteria here which proliferates. And the most important thing about cholangitis is to realize that there is cholangiovenous reflux, and that is because the biliary tree and the vascular sinusoids in the liver are at very close opposition, just one cell apart, and that can lead to sudden bacteremia. And these patients can be very sick in a very short while. So cholangitis is a life-threatening emergency which should require immediate drainage with or without stone extraction. Minimum just a stent into this can be a life-saving procedure. In our patients with stones, we found on magnification phase contrast and scanning electron microscopy, multiple bacterial colonies sitting on that with biofilm formation. And this is a very serious thing because these gallstones were always considered as innocent gallstones. But I will show you evidence as to how these are not innocent. They're full of bacteria, they're initiating inflammation and pre-neoplastic lesions. In a recent study, we found that patients with gallstones more often had sluggish gallbladder. That means the gallbladder's contraction did not initiate within 30 minutes of a meal, and there was delay in onset of this contraction. This quite often leads to mismatch of food entering into the duodenum and the gallbladder emptying, resulting in symptoms of dyspepsia in these patients. The other thing we found is that the patients with gallstones more often had static gallbladders. You can see 37% of gallstones had static gallbladders, and these gallbladders stasis was defined as something less than 40% GBEF at 1 hour. So we had a very large sample size, over 1,000 patients with and without gallstones, and we found that gallbladder stasis was definitely far more common in patients with gallstones. We found that patients with gallstones at 30 minutes as well as 60 minutes had significantly lower ejection fraction, the blue bars which you can see here, compared to their age-matched control patients. So the symptom profile in patients with gallstones, as highlighted, can be just incidental gallstones. They may be symptomatic or asymptomatic. Very commonly, patients come to some other specialty, have an ultrasound done, and gallstones are picked up, and these patients are referred to you. So our job is to assess, are they symptomatic, asymptomatic, or complicated, and accordingly plan their management. Among the asymptomatic gallstones, 80% of the stones in the gallbladder are actually asymptomatic. The probability of symptoms increase with age. There are two large cohort studies which I'll just share with you. 18% of them become symptomatic over a 10-year period of time. So nearly 1/5 of them become symptomatic in 10-year period of time. Usually it was understood that the patients, before they develop complications, first become symptomatic and then go on to develop complications. However, this may not be true. Some patients may present for the first time with a biliary pancreatitis or an acute cholecystitis, or they may present to you with gallbladder cancer. So this dictum does not hold true. This is what the Grepco study had shown, but it hasn't been substantiated later on. A patient who has asymptomatic stones can become symptomatic at any time, during travel, during exploring, or during pregnancy, or when they're astronauts. So that's why in these situations, it's better to have the gallstone tackled before people take up such kind of activities. So when the patient presents to you with acute cholecystitis, you have a stone which is obstructing the gallbladder. The gallbladder is distended. You can see that the gallbladder wall is thickened, edematous, and there's a lot of sludge within the gallbladder. And this gallbladder would present with biliary pain for more than 6 hours, for which you have to treat them initially with analgesics, antibiotics, as well as NPO and IV fluids, and offer an early cholecystectomy if things don't subside or they become complicated. In acute cholecystitis, when you have acute cholecystitis, the stone can, just migrate into the duodenum and cause a cholecystoenteric fistula, which will eventually require a surgical management. And here you can see a setting of acute cholecystitis with the stone migrating into the duodenum. After acute cholecystitis, there can be a free perf of the gallbladder, or it can go into the liver. Both of these need drainage. And in this situation, as a temporizing measure, a percutaneous cholecystostomy helps. You can put a tube directly from the skin through the liver into the gallbladder, drain, give antibiotic, temporize it, and then send it for surgery, because the surgeon will find it very difficult in an acute situation to handle such a kind of tissue. When patients present to a gastroenterologist with acute cholangitis, you can have a stone causing an obstruction to the CBD. And this is a situation where you have to give IV fluids, antibiotics, offer biliary drainage with ERCP. And if ERCP is not possible, patient is sick, then even percutaneous transhepatic biliary drainage can help as a temporizing measure. You may put in a stent into the biliary tree, or you may put a nasobiliary drain. Whatever you can do, you have to reduce the biliary pressures and as well as provide a route of drainage for the obstructed biliary system. Recently, over the last decade, people have started doing EUS guided interventions where you can put a direct access into the biliary tree if you cannot access the biliary tree through the papilla. Our ward is full of such kind of patients of gallstones who present to us with biliary pancreatitis. Unfortunately, if it happens during pregnancy, it offers a lot of risk to the mother as well as the fetus, as well as in the postpartum period. We see a large number of patients presenting to us with this biliary pancreatitis. And this sometimes makes us feel that this is such a preventable thing that if we had diagnosed the gallstones, we would have avoided such a life-threatening situation. So when in pancreatitis do you suspect it to be biliary? If the patient has associated supportive evidence in the form of a IHBR dilatation, CBD dilatation, elevated enzymes, especially ALT, at the onset with elevated alkaline phosphatase suggest a possibility of a biliary pancreatitis, especially in the presence of stone. Sometimes you may not have a stone in the gallbladder, but still you could have a stone in the CBD. When you see stones inside the CBD, these could have migrated from the gallbladder, or in a patient after cholecystectomy can de novo be formed in the CBD. And in such situations, ERCP and stone extraction is essential. And nowadays, there are sufficient techniques to be used at ERCP, even for large stones, obviating the need for CBD exploration by the surgeon, which increases the time for the surgeon in the operation theater. Only in the situation of multiple gallstones, large CBD stones more than 2.5 centimeters, in such a situation where you cannot extract all the stones through the CBD, then the surgeon can take a decision of doing both the things at the same time. When we studied the natural history of stones in the Danish cohort of 664 patients, those who were having colic was 12%. Those who developed CBD stones pancreatitis was 5%, acute cholecystitis in 3%, and they did not find any patient of gallbladder cancer. We are initiating a large study on asymptomatic gallstones in over 3,000 patients to see what percentage of them have this kind of a profile, and I suspect that we will have a different profile. In another large natural history study, the Cleveland cohort in 22,000 patients, 8.8% went on to develop colic or chronic cholecystitis, 3.2% had acute cholecystitis, 2.4% had biliary pancreatitis, 2.7% had CBD stone, and a very small percentage had gallbladder cancer. So this natural history study has shown that we have at 5 years, 10% become symptomatic. At 10 years, 20% become symptomatic. And at 15 years, 30% become symptomatic. So if we remember these figures, that at 5 years, it's 10%, at 10 years, it's 20%, and at 15 years, it is 30%. I think our job is done so that we can counsel our patients accordingly. Another interesting fact in this cohort study, it showed that statin use was the only factor which reduced the risk of it becoming symptomatic. They found that stones which are more than 1 centimeter, especially among women, those who are at a younger age, those who had long-standing stones, all of these increase the risk for becoming symptomatic. In India, in contrast to the West, we see a lot of gallbladder cancer. For the amount of gallstones, we see a large number of gallbladder cancer, because gallbladder is also the thinnest part of the gut, as I said, and because if malignancy develops, it rapidly spreads to the liver, and gallbladder is in a very anatomically busy area with the portal vein, the hepatic artery, the liver, the duodenum, the colon, everything beside it, all getting involved in malignancy. Then it becomes very difficult for the surgeon and painstaking for the surgeon to do a radical cholecystectomy to take care of such kind of patients. And usually once the patients become symptomatic with gallbladder cancer, their survival is very low. Their 6-month survival is less than 5%. So given this kind of scenario, I realized when we started treating these patients, we found that they have a dismal prognosis, and thus we started looking at means and ways to prevent gallbladder cancer and to prevent gallstones. So we embarked on this study. My student Dimple Kalsi has just now finished her PhD work on trying to study the relationship of stone and gallbladder cancer. So we hypothesized that the physical component, the bacterial component, and the chemical component may have a role in the pathogenesis of gallbladder cancer. And we had hypothesized that rough stones, large stones, hard stones, and dense stones are going to cause more injury to the gallbladder every time the gallbladder contracts. And once the bile is released, this is going to rub against the mucosa, resulting in repeated mechanical injury to the gallbladder. And we also hypothesized that these crevices may be places and hideouts for the bacteria, and that is why we know that patients who have bacteria on these stones, especially Salmonella typhi carriers, they are not going to become negative unless you do a cholecystectomy in these patients. And chemical injury, as I said, the bacteria sitting in the gallbladder can deconjugate various bile salts as well as the metabolites which are excreted by the liver. We have to remember that the liver is excreting a lot of metabolites, which is detoxifying, and gallbladder is just like the urinary bladder, which is going to have a lot of these toxins sitting there. So combination of mechanical injury, bacterial injury, and chemical injury, we hypothesize will increase inflammation, increase cell proliferation, increase metaplasia and carcinogenesis. And in the presence of stasis, all these will get accentuated. Long back, we did a study on whether the gallstones have any effect on the timing of development of gallbladder cancer. And interestingly, we found that among patients with gallbladder cancer who did not have stone, the mean age was 62 years. Whereas those who had gallstones, the mean age was 57 years. And those who were had gallstones and were of poor socioeconomic status, they developed gallbladder cancer at a younger age, saying that most of these risk factors act in an additive manner, and gallstones hastens the development of gallbladder cancer. What is the story of pre-neoplastic lesions? In contrast to Japan, where most of the malignancy can arise from an adenoma in the gallbladder, because in Japan, they have a lot of anomalous pancreaticobiliary junction. In India, Chile, Bolivia, and the Latin American countries, the pathogenesis of gallbladder cancer is through the inflammation, hyperplasia, metaplasia, dysplasia pathway. And especially if you have intestinal metaplasia, especially of the incomplete intestinal type, there is an increased chance of developing gallbladder cancer over a period of time of 5 years to 10 years. And metaplasia is associated with accumulation of mutations. So presence of metaplasia tells us that these gallbladders are at risk for developing gallbladder cancer. We recently did a study and we found that patients who are having metaplasia had lower gallbladder ejection fraction compared to those without metaplasia. And here you can see the ROC curve that we are able to predict presence of metaplasia in the presence of stasis of the gallbladder. So one thing which we have introduced into our armamentarium whenever we are seeing patients with gallstones is to look for gallbladder ejection fraction. And this is a study in which we have done symptomatic gallstones who are undergoing gallbladder ejection fraction before they undergo cholecystectomy, and you can find that there is gastric as well as intestinal metaplasia on pus and Alchin blue staining. So here on histology, we found that most of the patients have chronic cholecystitis in a spectrum of mild, moderate, and severe cholecystitis. So mild and moderate was fairly common. And we found that you have the gastric metaplasia or the intestinal metaplasia. The gastric metaplasia looks pink on the pus Alchin blue staining. You find it purple or for intestinal metaplasia. So you can pick it up on HNE, but pus and Alchin blue helps you pick it up far more definitively. Here you can see the intestinal metaplasia staining bluish purple, and here you can see it in the pink form, that is a gastric metaplasia. Here there is mixed metaplasia. Especially incomplete intestinal metaplasia is the most sinister out of all of that, as what we have learned from following up patients with precancerous lesions of the stomach. And here you can see hyperplasia, and we found one patient had dysplasia, and the one who had dysplasia also had metaplasia in adjacent areas. We studied the bacterial load in the gallbladder in those with stones versus without stones by 16S RNA. We found that the patients with stones had higher amount of bacterial load in the gallbladder. We also found that single stones versus multiple stones, single stones had greater bacterial diversity, multiple stones had lesser bacterial diversity, and more often grew organisms with maybe more pathogenic. We also found that the gallbladder mucosal changes in patients with gallstones. We found more often denuded epithelium. Here, the gallstone patients are 220. We had controls who were undergoing cholecystectomy for non-gallstone indications, like Whipple's gallbladder was coming out, or with hepatectomy it was coming out. So, or in patients with choledocholithiasis, the gallbladder was being removed. So, in these patients, when we looked at, we found that gallstone patients had more often denuded lining epithelium, hyperplastic lining epithelium, hypertrophy of the muscle, myocyte vacuolation, fibrosis, and RAS sinus prominence. We also found that patients with gallstones, 20% had metaplasia, whereas none in the control group. We had more often moderate and severe inflammation in the gallstone group compared to the control group. Another interesting thing we found, because we had a theory that mechanical injury causes more inflammation, and interestingly we found that our hypothesis was sustained by the data, that large size stones, hard stones, stones which were dense and sinking to the bottom of the tube, mean stone weight which was more than 2 grams, mean hardness of the stone which was more than 3,500 Newton, and mean volume of stone which was more than 1 ml. All these were associated more often with inflamed gallbladders compared to non-inflamed gallbladders. So gallstones, is it incidental or a risk factor for gallbladder cancer? We analyzed our data and we found 80% of the gallbladder cancer in our country is associated with gallstones. 20% is not associated with gallstones. As I said earlier, those who had gallstones were younger than the patients who were having no gallstones. So comes the question, is it incidental or is it related? So when I analyzed all the data which is there in literature, there is sufficient experimental and epidemiological evidence that gallstone is a risk factor for gallbladder cancer, and it fulfills all the Bradford Hill criteria for causation rather than just an association. Gallstones presence increases risk by 7 times increased risk for gallbladder cancer. Recent cohort study from Taiwan, in fact, showed a hazard ratio of 58. That is really high when they followed up patients with gallstones. And gallstones, we have shown that hastens the development of gallbladder cancer by 6 years. Gallstones invariably precedes the presence of gallbladder cancer. And there's temporality of the relationship and dose response relationship, as we have shown. Larger stone, higher stone volume. There's a study from China which has shown more than 6 ml stone volume and longer duration, more than 10 years, is associated with increased risk for gallbladder cancer. And as I said, 80% of the gallbladder cancer in India have associated stone. And interestingly, all young gallbladder cancers who are less than 40 years have gallstones. So you don't find young gallbladder cancers without gallstones. So gallstone has a role in hastening the development. Movement is life and stagnation is death. And that is why I think there is a role of taking care of stasis also in these patients. So what are the options once we have gallstones? What are the options we have? We have 3 options. Either you take up the patient for cholecystectomy, you can give medical dissolution therapy with ursodeoxycholic acid, or you can do a wait and watch policy. So now we have safe laparoscopic cholecystectomy. We have sufficient surgeons who can offer that with very limited chances of injury to the bile duct, and the surgeon should be ready to convert it into open if required. The other thing which has been found is that if you have symptomatic stones early in the course of illness, if you manage these patients surgically, it becomes easier for the surgeon than if there are repeated inflammation and adhesions and problems which happen at the gallbladder fossa. So gallstones which are symptomatic as well as those who are asymptomatic and at high risk for subsequent complications should be offered laparoscopic cholecystectomy. When we assess, we should assess the number of gallstones, the size of gallstones, and also whether the gallbladder wall is thickened or not. I would suggest a 3 mm is a good cutoff to tell us whether it is abnormal or normal. Anything more than 2 mm is suspicious. So we recently have proposed GB RADs. GB RADs, just like LIRADs and BIRADs, is a way of classifying at-risk gallbladder. And so we choose an experienced surgeon and get a laparoscopic cholecystectomy, and very important that all of them should undergo a careful histology. So we should have a low threshold to convert to open to avoid biliary injury, and surgery should be offered to anybody who has gallstones with associated symptoms or gallstones with associated gallbladder wall thickness, which is irregular, asymmetrical, it is at high risk for malignancy. And we have proposed GB RADs. GB RAD scoring can be given, and the probability of malignancy increases steadily as the GB wall thickness goes on increasing. And then we should offer them CT or MRI based analysis of the gallbladder wall. Incidental gallbladder cancer, you can see a stone, and along with that, there is a thickening of GB. Such patients should be taken up immediately for an early radical cholecystectomy. You can have a GB polyp if it is more than 1 centimeter or symptomatic, should undergo a cholecystectomy. If the patient with gallstone also has an anomalous pancreaticobiliary junction, you can see that the pancreatic duct and the bile duct are joining high up. This is at high risk for gallbladder cancer, and such kind of patients are more often seen in Japan and China, and these are patients who will be candidate for cholecystectomy. They have more of the KRAS dependent pathway for gallbladder cancer. If you have a stone which is very large, DL et al. Has shown that such kind of gallbladders should be taken out because the risk for malignancy is higher. Also, 3 centimeter stone tells you that it has been a long-standing stone. Presence of porcelain gallbladder, you can see the calcification of the wall again suggests long-standing gallbladder injury. So such kind of gallbladders are better taken off rather than left behind. However, there's recent change in some dictum related to porcelain gallbladder. If people are going to be in remote areas like Antarctica or on the moon or the Mars, it's better to have the gallbladders out. If they have stones, if they have hemolytic anemia, such kind of gallbladders also need to come out. If they are typhoid carriers, the only way to treat that is antibiotic followed by cholecystectomy. And if there's family history of gallbladder cancer and you find that the daughter is now having gallstones, it's better to have the gallbladder out. So what is the next option is ursodeoxycholic acid or wait and watch. Ursodeoxycholic acid can be given at 13 to 15 mg per kg in 3 divided doses. So that's amounts to about 300 milligram TDS or 450 milligram BD. It is given with the meal. Nighttime doses are more effective. And the indication is a radiolucent stone. That means the stone, if it is already calcified, will not dissolve with ursodeoxycholic acid, and only the small stones do well on urso. The cystic duct has to be patent, the gallbladder ejection fraction has to be good, and in the CT, there should be no calcification. If these prerequisites are taken care of, we can give ursodeoxycholic acid and repeat an ultrasound at 3 months to assess for dissolution or reduction in size. You tend to discontinue urso if the patient develops complications, intolerance, or at the end of 6 months also there is not significant reduction in size of the stone, is better to stop ursodeoxycholic acid. So the third option we have is wait and watch. Wait and watch in whom? In those who are completely asymptomatic gallstones, good ejection fraction, GB wall is also good, that is less than 2 mm, and they are motivated for follow-up. So only in this subset of patients can we consider wait and watch. So who are the ones who are at high risk asymptomatic stones who should be offered cholecystectomy, especially in a high incidence area? Let us look at that. If the age is more than 50, these are patients we have found have high incidence of metaplasia in our country, as well as high incidence areas like Chile, Bolivia, and Latin American other countries. They have found that anybody who's more than 40 years, they screen for gallstones, and if there are gallstones, they offer preventive cholecystectomy. In our country, we do not do that. We offer it in high risk group, and we individualize it for each patient. Female gender, high parity, obesity, low socioeconomic. Now, low socioeconomic is important because these patients come to the doctors only once. And after, if you reassure them and send them home, they'll not come back to you unless they come back again with gallbladder cancer. So we have to be very careful when we deal with this subset of patients, those with specific mutations, those with family history of gallbladder cancer are the high risk group if we look at the host factors. If we look at the gallbladder factors, large stones, multiple large stones, long-standing gallstones, stone volume more than 6 ml, porcelain gallbladder, associate Mirizi's syndrome, where the stone is stuck at the cystic duct and obstructing the biliary tree, GB polyps, anomalous pancreaticobiliary junction, CBD stone, GB stasis. These make the gallbladder vulnerable. And the third thing which makes the gallbladder vulnerable are infections like S. typhi and H. pylori, irritants, heavy metals, and occupational exposure. All these also increase the gallbladder to develop gallbladder cancer. So such subset should be either very, very closely watched or should be offered cholecystectomy. While waiting and watching, what should we do? Because we don't want the gallstone to cause biliary pancreatitis or CBD stones. So you should ask the patient to take small, frequent meals, ensure that the gallbladder function is adequate, that is GBF more than 40%. They should avoid prolonged fasting followed by a heavy meal. This is what the gallbladder is waiting for a kick. So this kick, when it happens, the gallbladder suddenly contracts and the stone passes from the gallbladder into the CBD, resulting in cholangitis, biliary colic, as well as biliary pancreatitis. So we should closely monitor them for symptoms, gallbladder wall and ejection fraction on a yearly basis. And if they have, they should be offered cholecystectomy. If symptoms develop, they should report SOS rather than ignore it and take some homemade remedies, and by that process delay their care to the hospital. So drawing a diagram and explaining to the patient is vital to keep them in the loop so that they will consult you whenever they have a problem. So to summarize, ladies and gentlemen, gallbladder and gallstones have an intertwined interrelationship. Static gallbladders promote gallstones. Gallstones in turn promote gallbladder inflammation and pre-neoplastic lesions. Combination of mechanical and bacterial and microbial injury promotes gallbladder mucosal injury. Persistent mucosal injury may increase the risk for gallbladder neoplasia over a period of time. Stones may cause mechanical obstruction to the biliary tree or through the gut, resulting in a spectrum of biliary disorders, which we discussed. Cholecystectomy, especially laparoscopic cholecystectomy, is a safe and effective management strategy. It is cost effective, and now there is sufficient expertise all over the world to do it safely. Endoscopic and radiological interventions are temporizing measures. I take this opportunity to now summarize with what should we do in patients with gallstones. If they are asymptomatic, they are high risk, then we can discuss with the patient and offer cholecystectomy or do a wait and watch policy. Especially if they have symptoms, if the gallbladder wall is more than 3 mm or the ejection fraction is less than 40, I personally send them for cholecystectomy. If they are symptomatic, they definitely need to go for cholecystectomy. If they are having only dyspepsia, dyspepsia is not considered as a standard traditional symptom of gallstone disease. I look at their ejection fraction. If the ejection fraction is low, this gallbladder is anyway not functional. You might as well have the gallbladder out. If it is more than 40%, we can follow up these patients. This is all our publications in this area, which I have put it into just these 2 slides. These are all the publications from which I have spoken, and many of the other things are in the process of getting published. And here we have our whole team, which has worked together to bring together all this data. And we have Professor Rakesh Tandon, who has been my mentor. Unfortunately, he is no more, but he continues as a guiding spirit for all this work on gallbladder cancer. And here we have Dimple Kalsi, Priyanka, Aarti, and these have been my PhD students. Harish and Deepa Thakur are presently working with me, and Pankaj and Surinder have been my research fellows. And we have Dr. Purna Chandra, Dr. Harshal, Dr. Noor, Dr. Harish, Dr. Nikhil, Dr. Rimpi, Dr. Tejinder, as well as Dr. Ravi Kiran, and Dr. Solanki, who have all been actively contributing as senior residents as a part of their thesis on this area. And I have my faculty, Dr. Pramod, Dr. Nagi, now Dr. Pankaj, who have been handling our radiology, Dr. Kaman, who's our surgeon, and we have nuclear medicine expert, Dr. Anish, Dr. Uma from histopathology, who has been painstakingly looking at all the metaplasias, Dr. Radhika, who has been our cytologist, especially for gallbladder cancer, Dr. Shalmoli has been helping us with the FTIR chemical analysis, Dr. Rashmi is our gynecologist in another study which we didn't present today on the role of vitamin D and gallbladder diseases. Thank you.